Hello, I'm Dr. Gregg Jossart, Director of Minimally Invasive Surgery at California Pacific Medical Center in San Francisco. Thank you for joining me today. This lecture that I'm going to give you will be on weight loss surgery. It's for patients considering weight loss surgery. A short disclaimer, I do not have any financial relationship with any company. The content of these slides and this lecture is for the sole purpose of patient education. Here's a brief introduction. The first part of the lecture will be on obesity and its effect on your health, and the remaining part of the lecture will be solely on bariatric surgery. It's 92 slides and approximately a 1-hour lecture. Over 45 minutes will be dedicated to weight loss surgery itself. This is a graph showing that obesity is caused basically by an excess of energy intake or too many calories consumed and not enough calories burned. This would occur over your lifetime. You may have a genetic predisposition to obesity, but during your lifetime you consume more calories than you burned off through exercise. Now, you may have had many successful diets where you lost 50 or 100 pounds, and you tipped the scale in the other direction where you reduced your calorie intake and increased your exercise to burn off more calories and you lost weight. But the problem at the end of that diet was you still had this large stomach that could easily consume calories, as denoted at the top here. Basically, it's incredibly difficult to lose weight through exercise because 1 hour of basketball, which almost no one can play, burns 480 calories, yet almost anyone can eat one cookie within just a few minutes. So this balance is very difficult to tip, and that's why weight loss surgery can be very helpful, because it can reduce your stomach size and reduce your calorie intake or energy intake. And then with the weight loss that happens, you can often start to burn more calories by exercising more as you lose weight. Another way of putting this is what is now known as the push hypothesis. In the last 20 or 30 years, we've developed an abundance of easy calories in our society, and they're readily available at gas stations, grocery stores, and so forth. And then we probably don't exercise or move as much as we used to due to elevators and automobiles and so forth. So reasons to consider surgery when you become obese: you've already tried a lot of diets and exercise programs and you lost weight, but you've always gained weight back, or you weigh more now than you ever have. You develop more medical problems and you're adding more medications. For example, you may have been on one blood pressure pill several years ago, and now you're on 3. Your medications are not controlling the problem. A good example would be diabetes, where every year you're increasing the amount and doses of medicines you're using. Worsening medical problems, that might be something like arthritis, where you had a sore knee a few years ago, and now you're looking at a knee replacement. Arthritis and these other problems also make it more difficult to move. And if you can't move very well, you can't exercise, and it's hard to lose weight if you can't exercise well. And even though you're trying to diet and exercise repeatedly over the months and years, your weight is still increasing. One thing you probably didn't know about is when you become obese, you have a much higher risk of 13 different cancers, and this will be addressed later in the discussion. And there's also a risk of early death with obesity. The decreasing the need for medical and surgical care is something you don't think about normally, but if you remain obese, you're more likely to have several operations for joint replacements, possibly amputations for diabetes, and other procedures and medical devices placed because of your prolonged obesity. By losing weight, you can hopefully prevent these things from happening or minimize them. So there's 3 main ways that obesity affects your health. The first is pressure. So when you become obese, you have increased pressure on your lungs and your breathing, and you develop sleep apnea and snoring problems. You develop high blood pressure, and then, of course, pressure on your joints, especially your hips and knees and ankles, and you end up with arthritis and joint failure. The metabolic component is where you develop diabetes and high cholesterol, as well as fatty liver. Many of you don't even know you have fatty liver when you become obese, but diabetes is probably the most common thing that people develop in terms of obesity and the metabolic syndrome. And then the inflammatory component, which many people haven't thought about over the years but is becoming more prevalent, is the high risk of cancers, which I already mentioned, fatty liver, and then the autoimmune diseases tend to be more common with obesity. So weight loss through surgery or even dieting can cure or improve all of these problems. So to mention cancer again, there's 13 different cancers associated with obesity. 40% of all cancers occur in the obese. The most common are breast and endometrial in women and colon cancer in men. So we always recommend you do your screening cancer at a younger age. So when I see you in the office, usually at age 50, I start recommending more aggressive cancer screening protocols. So a little New York Times article to help you understand how well weight loss surgery can work or how it's perceived. Dr. Twells is not a surgeon. She's an epidemiologist, and she published a paper showing that outcomes 25 years after weight loss surgery were very good. The patient satisfaction and quality of life was very high. And so she was quoted then in the New York Times on this. She said, "I haven't come across a patient yet who wouldn't recommend it. Most say they wish they had done it 10 years or sooner. It's the most effective intervention we have in healthcare." A VA study was also mentioned. It was published around the same time, and it shows that only 3% of patients actually return to their starting weight at 10 years. So there is a failure rate in weight loss surgery, but it's actually quite low. It's vastly underutilized. For 200,000 operations a year, 24 million people do not have the surgery that would qualify. And it's perceived as dangerous, but it's now been proven to be safer than gallbladder surgery. And this is just one patient's outcome at 1 year, but it shows you he's post-op 1 year. His pre-op weight was 346 pounds. His post-op weight is 211 pounds. He's consuming up to 1,200 calories per day. Most of his medical problems have gone. He doesn't have significant side effects. And he writes at the bottom that it changed his life. So that's a very typical outcome with weight loss surgery. So now I'm going to start teaching the actual elements of surgery itself, starting with my experience. I've been doing this for over 25 years, thousands of operations and tens of thousands of follow-up visits. Everybody stays overnight. I keep people in the hospital. I do not let people leave the same day. It's rare to have a readmission or ER visits. And one of the reasons people have their surgery in a hospital and stay overnight is because the insurance companies require that, and they often have that within what's called their Center of Excellence requirements. So a Center of Excellence is the term that many insurance companies use: Aetna, United, Optum, Cigna, Blue Shield. Blue Cross uses Center of Medical Experience, and some of the insurance companies also use a separate title, Center of Distinction. And basically this means that I have to prove good results and do over 100 or 125 procedures a year. Even then, the insurance companies may also expect you, the patient, to enter into a weight management program for 3 to 6 months within the last year or two. And it is not uncommon for me to have to talk with the medical doctor at the insurance company to try and get you approved for the surgery. We have a new hospital since 2019 that we're doing these procedures in, and it's a state-of-the-art, very nice place, all private rooms. So my job is to do the operation correctly, which I've been doing for over 25 years, and your job is to follow all of our instructions. We give you our 50-page book, which has all the details that we teach you in it, and that is reviewed with you in the office. So some basic concepts. You do choose the operation. It's up to you, not me, but I will teach you about the risks and benefits of each operation. We give you a little checklist to do, which is in the back of the book, and that might be like blood tests and EKGs and so forth. I always tell you to get in shape for surgery, lose some weight. That'll shrink your liver and thin out your stomach so the surgery's safer, increase mobility to reduce the risk of blood clots and pneumonias, and come in with good control of your medical problems, such as your blood pressure and your diabetes. That's what gets you in and out of the hospital in just 1 or 2 days. Follow-up is very flexible now due to the e-messaging system that we have on the electronic medical record, but we do tend to contact people at 1 week, 1 month, 3 months, 6 months, and annually. The instructions are strict, and they're in our goal weight guide, and I'll teach you more about that later on in the slideshow. We do try to maintain a long-term relationship with you so that you achieve durable weight loss. And accountability is a big thing here, because if you just have the surgery and disappear without following any of the instructions we've given you, or come back to check on how you're doing, and you come back 5 years later with a 20-pound weight loss because you sat on a couch and ate the wrong foods, it's unlikely a second operation can be helpful to you. But if you stay in touch and follow all the rules to get to goal weight, we can usually help you if you have a problem with 10 or 20 pounds. And there are new medications available now that can often help people who struggle with 10, 20 to 30 pounds after surgery. So the body mass index is the BMI. There's a BMI calculator on the internet, but so you understand the body mass index is your weight in kilograms divided by your height in meters squared. So it's kind of a three-dimensional number to help understand how obese you are for your height. So if your BMI is 35 to 40 and you have medical problems like diabetes or high blood pressure, your insurance company will usually authorize you for surgery. If your BMI is 40 or greater without a comorbidity, meaning you're otherwise healthy, you're on no medications, your insurance company will usually approve you for weight loss surgery. They will usually not approve you for a BMI of 30 to 35, but that may be changing over the next few years as evidence shows how good weight loss surgery is for this group as well. To give you an idea how BMI is not perfect, Arnold Schwarzenegger's body mass index was 37 during the peak of his bodybuilding years, yet he didn't have a significant amount of fat. So the problem with the body mass index is it doesn't reflect how much muscle mass there is for the amount of height and weight a patient is. But it's, in general, a good indicator for most of the public. So the medical conditions associated with obesity, the big ones are always diabetes, sleep apnea, arthritis, high cholesterol, fatty liver, cancers, and high blood pressure. Other associations include asthma, pregnancy and infertility issues, psoriasis, urine leakage, heartburn problems, and other autoimmune disorders such as fibromyalgia. All of these get better with weight loss, whether it's through diet and exercise or through surgery. So some people used to say, well, I've tried everything else, I'm going to try surgery now. And you should always think that what you're doing when you're choosing surgery is you're augmenting all the other methods. So diet doesn't work very well, but you have to be on a weight loss surgery diet. So we do include pretty strict diet recommendations. Exercise by itself doesn't work that well, but diet and exercise with surgery work great. And everyone has to see a psychologist, so we do try to make sure that you're sort of compliant with all the behavioral things, such as not addicted to any particular drugs or have any untreated depression orders and so forth, so that you can get a good outcome. And then there are medications that are newer in the last 5 years that do work better, but they still have side effects and they can be very expensive. And if you stop them, you can often gain weight back. But we're finding the medicines in combination with surgery really help people get a great result these days. So laparoscopic and robotic technique is always 5 small incisions. The robot incisions are a little bigger, but they're in the upper abdomen. The open operation is a big incision in the midline here. I essentially never have to do the surgery open. It can always be done laparoscopic or robotic. There is always a slight risk of converting to open, so we put that on a consent form that may happen. But I've never had to open someone up when starting laparoscopic. This is just what laparoscopic surgery looks like. On the inside, we have little instruments with scissors and graspers, and we have little energy devices that can cut and divide and seal, and we put things inside plastic bags and take them out through incisions. So in terms of the methods of weight loss surgery, there's restriction and malabsorption. Everybody gets restriction. Restriction is making your stomach smaller so you do not eat as much. We restrict your calorie intake. That's the good part of weight loss surgery. It works really well, and patients are very happy about. The malabsorption is something you have to think very carefully about, because that's where your intestines are stapled and split apart into 2 separate channels. The 2 operations would be the gastric bypass, or the Roux-en-Y gastric bypass, and the duodenal switch. The bypass, or the malabsorption, is very effective at helping you lose weight, but also over a 10 or 20 year period may also introduce numerous medical problems, including iron deficiency, diarrhea, calcium problems, osteoporosis, and so forth. So this is adjustable gastric band. It's almost obsolete now. It's done in less than 1% of patients. But this plastic ring narrows or restricts the top of the stomach so food gets stuck and you feel full on a small amount of food. It works kind of well for some patients, but the problem was too many people would get food stuck here and start having vomiting problems. And then the device itself could erode into the stomach or slip or break and have to be removed. So once insurance companies started approving a sleeve gastrectomy in 2005, a lot of the patients who normally would have chosen a lap band over a gastric bypass started choosing a sleeve gastrectomy, and that has since become the most common operation. So this has been widely approved by insurance companies since 2005 and been done since 2001. This part of the stomach, the greater curvature, is stapled off the right side of the stomach and removed. So you can see we're just dividing the stomach vertically. It's also known as a vertical gastrectomy. The part that's removed is a large part of the stomach that can expand and take on a lot of food, such as a large Thanksgiving meal. It has a lot of cells that produce ghrelin, which is one of the hunger hormones, and makes you feel hungry. The part of the stomach that remains behind is this narrow tube-shaped stomach, shaped like a sleeve, the sleeve of your shirt. So we call it a sleeve gastrectomy. It has all the nerves that sense stretch and pressure and fullness, and you keep the valve at the top of the stomach and the valve at the bottom of the stomach. But because it's so small, you now feel full on just 1 or 2 scrambled eggs or a meatball. And so people love this operation because they get early fullness, lasting fullness, and not too much hunger in between meals. And then they don't have any bypass of their intestines. Nothing has been done to their intestines. And there's no plastic ring or foreign body. This tiny little titanium staple line that is on the stomach seals over with a little bit of scar tissue in a couple weeks. You can go through airport security, you can have an MRI, and you can have a CT scan. Essentially, this operation has got the best safety profile and excellent weight loss. The gastric bypass is still fairly common at 20% of procedures. The stomach is divided up high, and then a piece of intestine is sewn into the stomach, so you have a small little stomach pouch, and then food empties directly into the intestine. This food travels by itself with no digestive juices. The digestive juices then come around from this other arm of the Y, and they mix with the intestine. So the concept here is if you eat 500 calories, you might waste off 100 or 200 calories in the form of diarrhea and have a better weight loss and possibly a better cure of your diabetes. This is a very good operation, but it does have some long-term problems. People can get stomach ulcers that lead to emergency surgery. They can have intestinal blockages at this connection that can lead to emergency surgery. And then they're at risk for chronic problems with iron deficiency anemia, osteoporosis, and diarrhea. The duodenal switch is a rare operation because it's fairly difficult to do and requires fairly intense follow-up. But it's a sleeve gastrectomy pouch with a lot of bypass of the intestines. So here, if you were to eat 500 calories, you might waste off 200 or 300 or more calories. So these patients tend to have more diarrhea and more nutritional deficiencies, but they will have a better weight loss and a better cure of their diabetes. Other operations that may be done at the same time, including gallbladder removal. This is a cholecystectomy. So if about 30% of people considering weight loss surgery have already had their gallbladder removed. We do an ultrasound before surgery. If you have gallstones in your gallbladder before surgery, I recommend we take your gallbladder out to avoid complications of gallstones, which include gallbladder infection, pancreatitis, and blockage of the liver. You can also form gallstones as you lose weight after surgery and need a gallbladder removed months or years after surgery. These are just various pictures of patients' gallbladders that were removed for emergency purposes or because they developed gallstones and had pain. A hiatal hernia is where a little bit of stomach bulges up into your chest. You can see in this drawing. The stomach is down here, but some is bulging up into the chest. The symptom you get from this is often heartburn. And about 40% of patients with obesity will have this hernia. And you can see in the picture down here, when I look laparoscopic, I can see an enlarged hole, and part of the stomach is sliding up into the chest. And here, some stomach is being pulled or extracted out of the chest. So about 40% of patients will have a simultaneous hiatal hernia repair at the time of their weight loss operations. Other things such as abdominal wall hernias, like a belly button hernia, can be fixed as well. Some people have already had hernia repairs with sheets of mesh put in their abdomen. This can create adhesions, which may prolong the operative time some. Here's two pictures of adhesions. This is just a simple little adhesion, which just take a minute to divide. And there may be more extensive adhesions from prior surgery, like hernia repairs, C-sections, hysterectomies, and so forth. This may take 15 minutes or 30 minutes to divide. The fatty liver is a spectrum. This is a normal liver, and once you become obese, you develop a thicker, bigger fatty liver, which can eventually become fibrotic, and then eventually this is early cirrhosis. So one additional advantage of having weight loss surgery is that by losing weight, you cure your fatty liver problem or partially reverse your cirrhosis if you've developed it. So usually a liver biopsy is done at the time of surgery, and that's just a little needle, takes out a tiny piece of liver, which can then be put on a glass slide and looked at under a microscope. So that report usually comes back 4 or 5 days later, and it almost always says some element of fatty liver, which usually gets better as you lose weight. Now we're going to discuss getting ready for surgery so they have a very good outcome with just 1 or 2 nights in the hospital. So everybody has to see a psychologist before surgery so that the insurance company can review that approval and authorize you for surgery. So you have to have psychological clearance. Stop smoking a month before surgery and don't start smoking afterwards. Smoking can lead to a catastrophic or fatal complication. Carbonation tends to stretch your stomach after surgery, so we ask you to try and stop that before surgery. And then if you were to resume it in the months or years after surgery, it would stretch your stomach pouch and probably lead to weight gain. Hormones, we only ask you to stop those a month before surgery because you have a slightly higher increased risk of blood clots if you're on hormones. Weight loss, it's usually a good idea to lose 5, 10, 15, 20 pounds before surgery so that your liver will shrink some and your stomach walls thinner. It makes the surgery safer for you. The heavier you are, the more weight I may ask you to lose. So if you weigh 500 pounds, I may try to get you to lose 50 to 100 pounds. Mobility is important. You do not want to have surgery if you're just broke your leg or if you're in a wheelchair. You want to try and be as mobile or active as you can. Generally, if you can walk the length of a football field, you're in good enough shape for an operation. We tell you to start your multivitamin B complex vitamin a few weeks or a month before surgery so that your tissues get loaded up before surgery. And then additional tests such as endoscopies and cardiac testing and so forth will all be determined at the time of the consult based on your age and medical health. Some simple things about vitamins. Start a few weeks before surgery. Don't buy mail order vitamins that cost $30 or $40 a month. Just buy a $5 or $10 bottle of vitamins that can last you 3 months. Chewables are best because they absorb easily. The B vitamins should be B1, B6, and B12, not just a B12 vitamin. Don't take too many. It's hard to get a vitamin deficiency, especially with a sleeve gastrectomy, so you don't need to take double doses. Nobody needs a B12 injection ever. And we check your levels at 1 year, and we'll determine if you do have a deficiency, if you need extra vitamins. When I see you for a pre-op appointment, either by phone or in person, there's 3 pages in the back of your book that you've already reviewed, hopefully, and you know all your instructions. But we do order your prescription meds before surgery, so you can pick them up and leave them at home. It's usually a pain pill, a nausea pill, an anxiety-type pill, and a spasm-type pill. Buy some protein drinks. Just don't buy a lifetime supply. Those things are available at all the stores nowadays, so just buy a case or something because you'll get sick of the flavors and the brand. And then everyone does a little bowel preparation with some milk and magnesia, and those instructions are pretty clear. Then you come into the hospital, you have the surgery, you stay 1 night in the hospital, you're walking within a few hours of surgery. Some people need 2 or 3 nights depending on their underlying health, their body weight, their mobility, and how far away they live. But generally you're going to be in the hospital 1 or 2 nights. When you go home, you're on liquids for 2 weeks, and we have 5 pages of instructions on that. Then you advance to a soft diet in week 3 and 4. And we do expect you to do lots of walking, light-duty activity. At 1 month, we generally tell people you can do full exercise, but many people do it before that. And then you can return to work in a week to a month, depending on how physical your job is and how much you like your job and how much time they owe you for sick leave. So the goals of the surgery are to lose your excess weight and keep it off. You want to cure your medical problems and get off your prescription medications. You want to have a much better quality of life, like run on the beach, ride on the rides at Disneyland, and go on better trips and vacations, more adventures. You don't want to have side effects. It's okay if you vomit once a year by eating the wrong foods or something, but you don't want to have a severe problem with vomiting or constipation or diarrhea. You don't want to end up in the hospital with additional surgery or wound infections and so forth. And one thing I like to mention to everybody is some of these side effects and complications are a little more likely with smaller pouches and in diabetics and anyone who gains some weight before surgery or those who have much higher starting weights. So everybody's a little bit different, and some people are at higher risks. But ultimately, achieving your desired weight is going to be highly dependent on how well you follow the diet and the exercise that we recommend to you. So a couple things we know from studies that shows that the 3-month follow-up predicts your 5-year follow-up. We've seen that with 6 months too. So everyone loses some weight in the first month or two. But how well you're doing at 3 and 6 months is going to predict your 5-year outcome as well. So we strongly encourage you to be compliant with the diet and exercise in that first 3 to 6 months so you really learn how to do everything correctly. And that's what's going to give you a good long-term result at 5 years. And remember, the operation's really good at restricting your calorie intake, but it's only a tool, and you can use it wrong. You can still eat consume liquid calories such as ice cream and fail weight loss surgery. And the operations are always good for 75 to 125 pounds. Those of you who have to lose more than 125 pounds, be aware that you will have to work harder at that, probably do more exercise, and it'll probably take longer to get all that weight off. This is a 20-year follow-up from the Swedish obesity study. It just shows that the diet group at 20 years did a good job. They were still at the same weight, which is pretty typical for dieters who are successful. They don't really end up at a lower body weight, but at least they don't gain more weight. The surgery group had dramatic weight loss in the first couple of years, but they put back some weight. And so you can see here the surgery gets the weight off, but the diet keeps it off. So we encourage everybody to try and get skinny from the surgery in the first year, and then if you gain back 10 or 20 pounds in the next 5 or 10 years, that's still a great result. So never feel like you're losing weight too fast or too rapidly, or you don't want to get too skinny. It just never happens over a 10 or 20-year period. Some of the side effects to address, generally they're very rare and they're often self-inflicted. Okay, number 1, constipation. That only happens if you don't take the bowel prep before surgery or you don't do a few laxatives in the first few weeks after surgery. Bleeding is incredibly rare. The last patient I've had that bled was over 500 patients ago, and he was taking Advil or ibuprofen the week before surgery, even though he was instructed not to do so. He'd also gained some weight before surgery, which made his surgery more risky. Long road trips. So that's the type of patient who has a month off from work and they're going to drive to Arizona and they're going to drive somewhere else and they're sitting in the car for 7 hours straight. You're more likely to get a blood clot. And then someone who's doing real well on their liquid diet in the first week, but they decide to have some chicken to see if it'll go down. Some people get away with that, but many do not. It may launch you into a cascade of vomiting, which would cause dehydration, and you'll end up in the hospital. And then some people are just high risk and higher body weights, and in those patients, we might actually give you blood thinners to reduce the risk of a blood clot. So that'll be a one-on-one issue that we'll deal with in the hospital. And then other things such as needing your gallbladder removed, belly button hernias, the appendix, and so forth, those are not complications. Those are just other events that can happen. I've not had a single patient in the ICU in the last 1,500 patients, so generally, by doing things correctly in advance, we should be able to get you home in 1 or 2 days. So how do we do that? You stay mobile and hydrated before surgery and after the surgery. So you've got to drink your liquids and you've got to get up and walk around after surgery. Lose that weight before surgery. Come in tip-top shape in terms of your blood pressure and your blood sugars. Don't come in with a high blood pressure and a blood sugar of 400. We'll cancel the surgery. So you have to stop smoking, and you cannot smoke after surgery. Don't take the Advil, Motrin, that stuff that can cause bleeding problems. And follow all the details that we teach you in the Go Weight Guide. So everything I taught you in the last 2 slides will keep you out of the emergency room. Okay. Again, if you eat solid foods in the first 2 weeks, you may launch a cascade of vomiting and dehydration that will lead you into the hospital. So do not do that. And then if you have a little problem, just message us or call. We're very available. And if you think your wound's a little red, just let us know. Generally, wound infections never happen. A little wound redness is normal due to the normal healing response. And I can take a look in the office and let you know if it's normal or if it's infected. But it's incredibly rare to have an infected wound. So now we're going to go into eating, exercise, tracking, weight loss, and weight maintenance. So the sleeve stomach, think of it like a two-way street, and we have a paragraph in the guide on page 34 that teaches you about this, but the stomach normally has very low resting pressures. And the esophagus, think of it like a clamp resting at 25 millimeters, so you can sleep at night and fluid doesn't come up into your throat. Then when you start to eat food, that esophagus can squeeze food into your stomach at 80 millimeters of mercury. That little stomach is happy with that first bite of egg or meatball, but if you try to eat a second bite real fast, or it's a big bite, all of a sudden that stomach pressure goes from 0 or 5 up to 100 or 150, and you start to vomit. So you know that you're eating too fast or too much or it's too tough if you start experiencing some left shoulder pain, belching, burping, coughing, sneezing, a runny nose, a heartburn symptom, a lump in your throat, or pressure in your chest. That's because you're trying to eat too much too fast or it's too tough. So we always try and teach you eat slower, softer, and smaller, and usually those symptoms will resolve. If you're spitting up food across the table, then you definitely ate too fast. You learn not to do that within just 1 or 2 episodes. So heartburn or reflux, many patients think when they get some chest pressure as they're trying to advance the soft foods, they're having a heartburn problem, and they'll try and take these omeprazole type drugs, they're known as proton pump inhibitors. The problem with these drugs is they're probably not really necessary or helpful in this setting, and they're associated with a lot of other problems such as Alzheimer's and kidney failure and low magnesium. So we try to get you to avoid these and just use a basic Tums or Rolate or an H2 blocker when you do have heartburn. And usually heartburn, if that's what you think you're having, is usually due to trying to eat too fast, too much, or you've triggered heartburn by eating the wrong thing. So that would be certain acidic foods or juices like oranges or orange juice or cranberry juice. A lot of coffees are very acidic. Certain foods can lower the pressure of the sphincter valve that is a junction between your esophagus and stomach. And that includes alcohol, garlic, onions, tomatoes, citrus, caffeine, drinks, and peppermints. Your stomach will empty slower if you eat fatty meals, such as foods with French fries or oils, or foods that include French fries, fatty meats, and then any food that has a lot of oil in it, like stir fry. The new weight loss medications can also slow down your stomach emptying. That's one of the reasons they work for weight loss, and that could give you a little bit of a sense of heartburn. Some of the artificial sweeteners that are in these new beverages will often give you sort of an irritable bowel or upset stomach or heartburn problem. And then if you're eating larger foods and eating late at night, that'll give you heartburn. So identifying these triggers is a process of elimination. So some people can figure it out pretty quickly because they'll notice that they had a particular drink or a food and they had heartburn within 30 minutes to an hour. Many of you had heartburn before surgery as heartburn is very common with obesity. I'm not going to read this entire paragraph on constipation, but it is on page 40 in the book. And the main tip here is don't let yourself get constipated. Stay ahead of it by taking some mild laxatives or magnesium, prunes juice, Dulcolax, and so forth. So tracking your calorie intake and the calories you burn off through exercise. This is an old study from 1992 before we had smartphones, but it just shows that when people try to record their calorie intake, they thought they were eating 1,000 calories on their diet, but they were actually consuming 2,000. And nowadays, all the foods have labels on them to tell you how many calories are in the food that you're eating. Plus, with the phone apps, you can actually identify how many calories are in an egg or an apple or a carrot. So you should be much better at tracking your calorie intake. And then exercise is on the phone apps now too, so we should be better at that. But even then, I think they're a little bit difficult to be accurate because, say for example, an hour of swimming might be something like 500 calories, but none of us can swim like Michael Phelps, so he might be the only person who can actually burn 500 calories swimming in an hour. So your calorie intake changes over time. The general goal is to eat 600 calories per day during the rapid weight loss phase, which is in the first 6 to 9 months. Now that might creep up a little bit to 700 or 800 calories a day if you're exercising a lot and if you're a young, big man. Once you get to maintenance, okay, you're now, say, 9 months or a year post-op, you're at a good weight, your calorie intake will increase some, and that's 1,300 calories per day on average. A petite, smaller person might only be on 1,000 calories a day, whereas a young, big 6'4" person who weighs 240 pounds, they may be eating 1,600, 1,800 calories a day. Most people who eat more than 2,000 calories a day will gain weight or become obese, whether they had surgery or not. You have to be doing a significant amount of exercise to consume 2,000 calories a day and not gain weight. So as I said, weight loss always occurs in the first 1 to 3 months, but then it starts to slow down. Your body doesn't want to let go of the rest of that weight. And so your pouch gets a little bigger, and you make the mistake of starting to eat a little bit more and more, and you're not realizing that you're now eating 800 or 900 calories a day, and you're making some of the wrong food choices. You're eating more because you're starting to eat softer foods because you can get away with eating more of them. And then you're celebrating at 3 months because you lost 50 pounds, so now you're having a recreational eating experience every night with wine and cheese. Don't do that. You still have more weight to lose. And then reasons not to exercise or not to burn calories, things such as work is stressful, the weather, you sprained your ankle, and so forth. So no matter what happens, you should always try to find a way to burn calories, whether it's through work, stress, personal events, injuries. There's always something you can do to burn off calories. So stay active. And then stay focused and determined. Don't just go after 3 months and 6 months and feel like you've done a good enough job. You lost 50 pounds and you're not even going to think about or worry about that last 40 or 50 pounds. So stick to it until you get to goal weight. So the protein drinks are pretty simple. They're widely available now. Every protein drink you have should have more than 15 grams of protein and less than 6 grams of carb. And the real trick is that some of them, such as Boost, Ensure, and so forth, have more than 6 grams of carbs. They might have 30 or 40 grams of carbs. They have a ton of sugar in them. Do not drink those. And then after the first couple weeks, if you can eat some soft foods and so forth, you can start tapering off protein drinks. The only people who tend to drink a protein drink beyond 1 month is because they're using that as a replacement for breakfast. Instead of eating eggs or something like that, they might just have a protein drink for breakfast. Or some of the big young men who are really hitting the weights a lot might have extra protein drinks to help build muscle mass. And then these are all the kind of no-no drinks, if you will. They have no nutritional value, and they probably have a lot of carbs in them. So you have to understand your calories in order to choose them wisely. So fats, proteins, and carbs are the big three. Fats are the most dense. They have 9 calories per gram. And the bad fats, of course, are butter and Crisco. The good fat is olive oil, but it doesn't change the fact that basically a tablespoon of fat, whether it's olive oil or butter, is going to have 120 calories. So try to minimize your use of oils and fats, even if it's good fats. Protein is 4 calories per gram. And usually it's protein that you need first to help try and preserve your muscle mass as you're losing weight rapidly. So that's why we encourage protein drinks and then the lean proteins such as fish and chicken, and try to minimize the fatty proteins such as cheese and beef and pork, even though those still are decent proteins. Carbohydrates are the same as proteins in terms of 4 calories per grams, but they vary, very wildly in how good they are for you. So for example, processed carbs such as a cracker, you could probably eat hundreds of calories of crackers without vomiting, but they have no nutritional value. Whereas produce, such as fruits and vegetables, you would probably only eat 25, maybe 50 calories, and you would be full for hours. So you always want to stay on the perimeter of the grocery store, consume produce, and avoid the processed junk food. Okay, water's a freebie. It has no calories. You can drink all you want. Always try to drink low-calorie liquids. Many low-calorie liquids have artificial sweeteners that may upset your stomach a little bit, so you may ultimately just prefer water or a little bit of fruit-infused water. And then I just mentioned the processed versus natural. Always try and, as your stomach gets a little bigger, always try and chew your food or eat your food in its natural state rather than drinking it. And that goes for protein drinks versus eating protein. Okay? You're going to see many more slides with pictures on this. So the liquid calorie amnesia problem. People have to understand that these stomach pouches that you have from surgery do not restrict any form of liquid calories, even milkshakes. So if you have some liquid calories that work during the day, you may not count them as calories consumed, but you consume calories, and they do count. And generally, if you drink liquid calories, you don't eat less food or chew on less food because of that. So we try to really get you to stay on minimal liquid calories. Carbonation is only a problem, even if it's carbonated water, is only a problem in that we think it stretches your stomach pouch and leads to you feeling more hungry and eating more food over the next 5 or 10 years, and probably increases your weight gain a little bit. In the mornings, oftentimes after surgery, you feel dehydrated by 10 a.m. And you don't realize that you're dehydrated. You feel actually hungry, and you try to snack on some food, which doesn't work very well, so you keep snacking. So we always tell people in the mornings, if you feel hunger, it's often dehydration misinterpreted as hunger. Drink some water, and you'll see that hunger probably subsides. So water loading, it's hard to drink and eat at the same time after surgery because your pouch isn't big enough, and you may flush the food through, or you may vomit or spit up some food. So we try to get you to drink water in between meals. Usually people can drink 3 to 6 ounces of water in just a few minutes after a week or two post-op. And so again, drink in the morning if you feel like you're hungry, because that'll help with that. And don't start snacking. The soft calories. So some patients get frustrated because they're trying to eat a little bit of apple or broccoli or something, and it gets a little stuck and they maybe vomit. They don't tolerate it very well. So they start choosing soft junk food like Cheetos. Don't let that happen. In some ways, a small stomach pouch will make you feel like you're becoming a junk food eater because you're starting to graze or snack. But you want to graze and snack on healthy foods, not just junk foods. And this is some pretty good medical literature supporting the fact that you should always eat your fruit and not drink it. Everywhere you go now, you can buy one of these juicers or blenders. It seems to be the popular thing. But in the British Medical Journal, they found that people who were juicers had a much higher rate of diabetes than people who ate their blueberries. And then in the International Journal of Obesity, they found that if they gave people 400 calories of juice versus 400 calories of fruit, they drank all the fruit juice, but they didn't eat all the fruit. So eat your fruit, don't drink it. And this is another example of, frozen berries. If 1 cup is only 60 calories, but if you, one apple is maybe 50, 2 apples, maybe 100 some calories, but a glass of juice or some type of frozen drink like this might be 500 calories, and you would have no problem consuming all of that. So your calorie intake can increase dramatically if you start to consume liquid calories. And so this is a paragraph in the Go Weight Guide as well that you can read on what we just discussed. In terms of sweeteners and sugars, the natural sugars that are bound up in the fruits, such as apples and bananas, are fairly difficult to digest and release slowly from this fruit. So we always tell you it's okay to eat melons and other fruits, produce in their natural form. That sugar is bound up in the fruit, and you don't eat too much of it. The processed sugars have over 70 different names. They're easily digested, and you consume too many of them. It's often fructose and other sugars that are particularly bad for you and will lead to increased fatty liver disease. And so we try to get you to minimize all of these, and you have to watch out for health food claims because you'll get tricked into eating more of these just by the fact that the box might say no high fructose corn syrup. So again, watch out for everything in a box and a bag when it comes to artificial sweeteners and sugars. So what can you sweeten your drink with instead of sugars or your foods? You can add some lemon or cucumbers, but coconut water is not one of them. So you can get real creative with fruit infusions. The other problem with most of the artificial sweeteners, as you see over here, none of them have ever been proven safe in humans. Some of them have shown to prove tumors in rodents. And so the one that's sort of acceptable, of course, is a stevia leaf extract. But you have to watch out for, because some of these beverages now, they have a proprietary blend of artificial sweetener or stevia and then a sugar alcohol. And it may give you heartburn or diarrhea problems or irritable bowel type syndrome. So watch out for some of the artificial sweeteners in the beverages that you're drinking. And of course, if you do start getting hooked on fructose or sugars again, in the forms of candies and chips and so forth, we know that they kind of trigger the dopamine pathways in your brain, much like alcohol and other drugs do. So in some ways, sugar addiction is similar to drug addiction. So we do try to warn you to be careful with consuming any type of sweeteners, because usually the surgery is really great for kind of breaking your sugar addiction, but it can sneak back in. It can sneak back in a couple years after surgery. So again, the box, I mentioned before, watch out for the health claims, because the front of the box might say something like whole grain or no fructose or low fat. If it says low fat, that usually means high sugar. Whole grain usually means there's a couple pieces of whole grain in there, but it's really not going to be healthy for you. It's a highly processed food. The one thing about foods in a box or a bag is the palatable trick that they use. They'll often make them a little extra fat or a little more salty so they're more palatable, and that will get you to eat more. And so the reason you want to eat more of the fruits and vegetables is because the work of digestion to break up the pulp and the fruits and vegetables is basically a form of exercise. You can elevate your daily calories burned by up to 15% just by eating fruits and vegetables. Whereas if you're drinking calories or eating them out of a bag or a box, you're not really doing that work of digestion. So some of the quick do's and don'ts of snacking. If you're snacking at work, you got to watch out for that, because you might be snacking on 50 or 100 calories every hour on crackers or something that you're not paying attention to, or the candy bowl, and you don't count those. So watch out. You better count those because they add up. And generally, if you're snacking, that means you're not exercising. You're doing something else, right? So if you're out exercising, you're probably not snacking. So avoid snacking as best you can. And you want to go more for the bariatric snacks and not the junk food snacks. So examples of bariatric snacks would, again, be the popcorn, jerky, nuts, and produce, such as cucumbers and carrots and apples. Okay, just 50 calories often make you feel quite full, whereas junk food snacks, you can eat hundreds of calories of Cheetos and Oreo cookies and never feel full. So again, avoid the high-calorie, easy-to-digest snacks such as chips and crackers and ice cream bars and so forth, and try and eat more of the produce, edamame, raw fruits, the Greek yogurts, the frozen berries, and so forth. Another example is get rid of the chips and crackers and eat the fruits and vegetables and the produce that I keep mentioning. By the way, spices are okay. There's no limitations on spices. These protein bars are often like a candy bar, if you will, so you should just stay off that stuff. It's highly processed, and eat the real fruits and produce. Another word about oils. I mentioned how dense they are. They're 9 calories per gram. 1 tablespoon is 120 calories. Even the healthy oils have too many calories. So, use sprays or use your oil sparingly when you cook, okay? Some of the substitutes might work pretty well, but just try not to use too many fats or oils. Timing of your meals. So once you're 3 months post-op, it almost seems like you can sit down and eat meals. So the general rule is about 5 hours apart. Try to start with some protein, maybe as much as 2 to 3 ounces, but maybe not at 3 months. And then just eat for 15 minutes. Don't just serve up big plates of food and then try and sit there for 60 minutes and eat. So kind of time yourself. Eat that small plate of food that's maybe 200 to 300 calories. And then avoid drinking during and right after eating. Once you're lost all your weight, it's a year post-op, your stomach's a little bigger. You start out with some protein. You eat some fruits or vegetables that aren't cooked too much. And generally, a meal might be 300 or 400 calories. By the end of the day, hopefully you've eaten about 1,200, maybe 1,300 calories. And that's about the amount of food that most of the world lives on per day. And it's actually more calories than a large portion of the world lives on each day. So it's a decent amount of food. More than 1,200 or 1,300 calories per day is probably too much unless you're exercising a lot, and then you might increase your protein intake. So these are some pictures of food. This would be a plate of food, some meat, vegetables, an apple. It's 144 calories. All of these plates of food are a patient who made these more than 2 years post-op and could sit down and eat this over 15 to 30 minutes, and they're all less than 200 calorie meals. So volumetrics is published in books by Dr. Barbara Rolls. The concept is good, but it doesn't teach you about how to eat with your small stomach pouch. So I just want to mention that you want to realize that as your stomach gets a little bit bigger, you're going to eat more food. And what you don't want to eat more of is more bacon, carrot cake, brownies, and potato chips, right? You want to realize that you want to eat more of the produce, especially like vegetables that aren't cooked as much. So early on, you might cook your broccoli or your asparagus to a much softer level so you can eat a little bit more, but as you become more than 1 year post-op, you want to make your vegetables a little tougher and your fruits a little tougher, so you might want to eat more apples rather than bananas and more minimally cooked broccoli or Brussels sprouts. And a good rule of thumb is 3 Brussels sprouts or just a cup of vegetables is 50 calories. So usually you can stay stuffed on 50 calories of vegetables, where it might take you 500 calories of these other high calorie density foods to feel full. Nuts are always a good form of snacking, so we've always encouraged nuts as being a useful way to snack, but you do have to realize that if you're nibbling away on nuts all day long, they can add up. So 40 almonds is 300 calories, and you can see it's pretty easy to nibble away on 300 plus calories a day on nuts. What you do to your vegetables matters. So spinach, a cup of spinach is only 41 calories, but a cup of cream spinach is 134 calories. Some roasted asparagus, 27 calories in 1 cup, but if it's made into risotto, 400 calories. A plate of what's called crudité, you can see here 3 of these little peppers is 25 calories. It could take you years to be able to eat more than 3 of these in one sitting. And then it's what you do. If you start loading up your vegetables with lots of dips, instead of eating 25 or 50 calories, you may be eating 200 or 300 calories. Starches, we ask you to avoid starch in the first year after surgery. Okay, now you're 1 year post-op, you got a great goal weight, you want to introduce some starches. Some of the breads, white bread, smart white bread, that stuff has no nutritional value. Some of the wheat breads may actually make you feel quite full and only be 70 calories, so try it out. Rice in general isn't going to be a useful starch in your diet, but if you're exercising a lot, it's certainly reasonable to try some rice. Cream of wheat really has no nutritional value, but people still think it's got a certain amount of enough protein, but it doesn't. And then oatmeal and spaghetti, they can be okay, but watch out. A lot of pastas get buttered up and oiled up in lots of sauces, so be very careful. So again, some whole grain toast might be a great way to go. The rest of these, be careful with. Proteins, the lean proteins, as you can see, lean turkey and roasted pork, 100 calories is a lot of food, whereas fatty ground beef may be very little food. So watch out for the amount of fat that's in your protein. It will affect your calorie intake. And then here's a good idea of what 100 calories looks like. So you can see no one's going to get skinny eating gummy bears, cheddar cheese, and M&Ms, but they can certainly eat those things when they have a stapled stomach pouch after surgery because they go down pretty well. But these vegetables don't go down very well at all, so you would only be able to eat 20 or 30 or 50 calories. Same for fruits and vegetables. This gives you an idea of what 200 calories looks like in terms of fruits and vegetables, and you can see how you can stay thin very long on eating produce. Alcohol is just like fat. It's 9 calories per gram. Interestingly, I don't think people gain weight back drinking alcohol after weight loss surgery because you tend to be a bit of a lightweight and you pass out, so be aware of that. But again, just a half a glass of beer or wine or whatever can be 100 calories. So if you're sipping on a bottle of wine all night long, you might consume 300, 400, 500 calories. So be very careful. Now, physical activity, this paper I'm mentioning specifically because it was a paper where they studied 40 patients 6 to 18 months after weight loss surgery. So they knew they were being studied, yet they found that these patients still spent 70% of their time in sedentary activity, just sitting around. Only 5% of their time was spent in moderate or vigorous activity. And we know that if you sit for more than 6 hours per day, you have a 15% higher chance of developing diabetes. So there's never a good time to sit around. And so the rule is try and get 10,000 steps a day, and that might be 4 or 5 miles. It might take you 2 hours. You might have to do it in 2 separate walks. But if you can exercise more, join a class, join CrossFit, Zumba, Soul Cycle, whatever you enjoy, and start doing that for 60 minutes several days a week, you'll get a fantastic result. And I have not seen limitations with this surgery. I have one patient who has been running 100-mile endurathons as early as 3 years after a sleeve gastrectomy. So generally, you can become a CrossFit champion or a marathon champion if you want. I'm mentioning magnesium, vitamin D, and constipation here because it's rare to get deficiencies of these, but constipation is a bit common. So one of the things you can do if you've had underlying vitamin D problems and you have some constipations, we recommend you just take a daily magnesium supplement at bedtime. It can help you sleep a little better, help with your cramps. It helps with your vitamin D, and it's also a mild laxative. So this is something that we often teach people in the first month or two after surgery if they're having some issues like this. So as I mentioned before, the follow-up is flexible. We do like to stay in close touch with you at 1 week and 1 month. And then generally you're doing pretty well up until 3 months. And then 6 months is when we catch you doing well enough to get to goal weight or starting to fail, and we take an action plan. Some of you who weigh 400 pounds will need more intensive follow-up, and we may introduce medications early on after surgery. At 1 year, that's a good time to check your labs, and some people want to have plastic surgery at the 1 year mark. That's fine to do. And in general, I tell people at 5 years, you probably should have an endoscopy, colonoscopy, and that cancer screening stuff should start up again. Tracking yourself. This is very important. In the middle here, everybody wants to weigh themselves every day and maybe multiple times a day. That's meaningless because your weight changes by the hour don't indicate how well you're doing. The weekly weight loss is most important because if you weigh yourself every week on a Friday or a Sunday or Monday, you can track that on a calendar and shoot for weekly goals so that if you lost 1 pound when you were supposed to lose 4 pounds, you could exercise more that following week. So the weekly weight loss results are actually very useful for tracking. Daily weight loss results are not. If you only weigh yourself once a month or not at all, and you wait to come into our office to weigh, you are not going to get a good result. You have to be committed to kind of a weekly outcomes on your goals. And we have these papers. Most people just use their phone now and track their weight on their phone app, and they can track weekly weight loss that way. So what happens if you're not losing enough weight at 3 months or 6 months, or you're 1 or 2 years out and you gain 10 pounds? Now, I say this assuming that you follow up. What you cannot do is have surgery and then disappear right after surgery and then call 5 years later and say, hey, I never exercised, I didn't listen to anything you taught me, and I only lost 40 pounds and now I gained back 30 pounds. So I can't help people like that. I could offer you more surgery, but you won't get a good result. So let's say you're 6 months or 9 months out, you've started into maladaptive eating. That's where you start grazing on some soft junk food at work. So you got to stop that. Or you're drinking some liquid calories, so you got to stop it. Pouch dilation is because you introduce carbonation back into your diet and you're stretching your stomach out. Or you're not exercising enough. You're just walking 1,000 steps a day. You're not walking 10,000 steps a day. Medications can cause weight gain or slow your weight loss. So if some doctor gives you prednisone or steroids, pain management doctors might give you narcotics that can slow your weight loss. Many of the antidepressants are associated with obesity and weight gain. There's over 30 medications that can actually cause obesity, so be very careful about starting prescription medications. And then there's always personal stressors that you've had to deal with too: death, divorce, work stress, injuries like a broken leg can definitely impact weight loss. It's really difficult to have true failure, which is going back to your starting weight. I've only seen one patient with that in the last 5 years, but it can happen. And so if you're 6 months post-op, you should have seen us. But if you're 1 year and you still have 20 pounds to go, call us, see us. If you gain back 10 pounds, let us know. We can help you with that. But don't gain back 50 pounds and then call. Okay, so stay in touch. So one of the things you should be aware about eating behaviors, this is an Italian study from 2016. It shows that people do great for the first 6 to 12 or 14 months. They reduce their calories. And interestingly, after that 1 or 2 year mark, it looks like people, especially after 2 years, have a higher craving for sweets. Not necessarily fats or total calories, but it's sweets. So be careful for that sort of desire to consume sweets, again, 1, 2, 3 years post-op. We usually try and help you with that too. We recommend you have a little protein bar or a chocolate protein drink or something like that. But don't start eating out of the candy bowl, that type of thing. So what methods do we have to get you to goal weight or get you back to goal weight if you gain a little bit? Sometimes people do really well in meal replacement programs, or even a simple basic Weight Watchers program can get you back down, get that 20 pounds off. It may be an exercise issue. You're just not doing enough and you do feel good enough to exercise more. It may be some behavioral things, like we said, grazing or snacking or eating at night or eating at work. And then there are medications that can be very helpful now for 10, 20, 30 pound weight losses. We've had several patients come in and get started on some medicines, and we've seen weight losses of up to 30 pounds, which is essentially the weight that was gained back 5 years or more after the surgery. And then additional surgery, I can offer it to you, but the results are very disappointing. It's often introduces much more risk and much more side effects for a weight loss that may only be somewhere between 15 and 30 pounds. So this is a slide showing the medications that are available now. Phentermine's been around since 1959. These are the newer ones that some are injectable, some are pills. They're very hard to get a hold of. Insurance companies don't want to pay for them, and they can have some side effects, but they are available. So some people have been using them, and they have helped people lose an additional 20 or 30 pounds in the first year, or if they gain back some weight a few years later, it's helped them. This just kind of shows if I do an operation where I convert your sleeve gastrectomy to a duodenal switch, or I convert your sleeve gastrectomy to a gastric bypass, you would see some additional weight gain. So here's if I just sleeve your stomach a second time, you lose basically 2 kilograms or 5 pounds. If I bring you all the way to the most powerful operation of duodenal switch, you might lose up to 12 kilograms, which would be something like 25 to 30 pounds, but you might have significant diarrhea problems. So this is the problem with trying to go second chance surgery, if you will. You've got to do it right the first time. The second operations don't really work that well. So the best way to get a good result is to come in and have a sleeve gastrectomy at a lower body mass index. It works great for people with a BMI of 35 to 45 or 50. If your BMI is over 50, it still works, but you're going to have to work harder. You may need to consider one of those bypass operations. You have to realize that your long-term calorie intake is probably going to be somewhere around 1,200 calories, plus or minus a few hundred calories per day, depending on your ability to exercise. Yes, you do have to exercise, and that's a good thing. You'll feel better because of it. Watch out for medications that cause weight gain. And then if you have a little struggle with 20 pounds, seek help. Let us know. We can get you connected with the right doctors or give you the right ideas to get back to that goal weight. That's the end of the talk. Thank you for attending it.